Rama, tu nous entends? You hear us?
Okay, perfect. So we can start.
Right.
Great. Thank you for joining us for this conference on scaling local and digital solutions for healthcare access. I'm Mireille Chagang. I just want to say hello because I had a great pleasure to organize this conference with these three incredible entrepreneurs. And so I will just leave you, Stéphane. We just leave you the floor. Thank you, everyone.
Hello, good evening to all of you. I think especially the audience connected from abroad. I know there's a lot of people connected from Africa. And we are a small group here sitting in Brussels, in ICAP, the incubator in Brussels. It's a pleasure for me. We were here some years ago for another conference hosted by the working group of Because Health. It's a pleasure for me to do it all over again, to do a new. A new conference of the working group. So first of all, before introducing our guests, a small word on Because Health. Because Health, the organizer of this session. Because Health is a platform of global development in health projects. And so surprisingly, I'm sitting here and I'm a bit not that comfortable because these two guys are not doctors, they are engineers. And so I think it's a bit a strange situation. A lot of working groups of Because Health, they work with health professionals, and it's really good to see here that we are connecting with engineers on same objectives. So Because Health, international platform on global health, hosted in Belgium at the Institute of Tropical Medicine, with I think a lot of working groups, one on medicament, on drugs, one on human resources for health, one on social protection, one on e-health, one on mental health, and so on. You find it all on the website. And very important, you see on the slide, a big event next year, and that will be a 2 days conference on breaking taboos in global health. And I say very important because it will be built around 5 tracks, and one of the tracks that were retained for the conference next year is new technologies, digitalization, and so on. So there again, go onto the website of Because Health and find out what the conference will be about. So, but without further delaying, very happy to have Joren and Steven with us. I think they have very important messages and experiences to share on digitalization and how digital can improve the access to health. And so I think it will be a good conference. And I always like to start my introductions with the provocative questions. Why in fact, are we going for digital? Is there any added value except the value that we think that is just good and that it leads to better quality? But I always like to be provocative, and I always like to say to the people, well, if you think it is, please prove that indeed there is an added value of digitalization in health. And I think today, with Joren and Ugani prosthetics and with Steven on smart glasses, that we will have 2 excellent examples on how digital can improve the quality of lives of our partner beneficiaries, our citizens in Africa and in all over the world, in the global south and the global north. So, without further delaying, I'd like to give the floor to Steven. Steven Cerneels, you might know, he's the co-founder of Iristic, and he's still board member. He's an engineer, and he has been in digitalization for decades. And I think is really one of the founding fathers of the smart glasses that we progressively see more and more appearing in our African contexts and settings. So Steven, please feel free to add on your bio, and the floor is yours.
Thank you very much, Stefan. I'm going to elaborate on my bio. Is that the right sentence? Yeah, thank you. First of all, don't be afraid of engineers. I truly think that the medical people, doctors, nurses, should still be in the forefront, should still be in the lead. I think we engineers can support, we can enable, but the true hard work is still with the medical people. And that's, I think, also one of the messages I'd like to give. It's the combination of the different disciplines coming together, even more than doctors and engineers. We need more to make it successful. I have three kind of phases in my presentation. Very briefly, an introduction, so you know what I'm talking about. Second, which is, I think, the bulk part of my presentation, is the case in Congo DRC. We've now a couple of more cases throughout Africa and starting in India. And later, I want to zoom out a little bit from the case to, let's say, the broader spectrum, so that yeah, you can also go from the anecdotal to the more general conclusions or potential discussions. So the smart glasses actually started as an industrial project and still are a very industrial project, but we thought that we should use this technology and this invention, and a lot of our R&D has gone into that, also in order to create access to affordable quality healthcare in underserved areas. And the kind of agreement we have between the Iristic business approach and the social in motion social approach is that the social in motion does not have to contribute to the whole R&D. The whole R&D is taken, and that's a big part of the company's expenses, is taken by the business. They have to do that anyhow. So in a much lower price tag, we can create affordable access to this technology in this way. Second thing is the glasses itself. Very quickly, people here in the room can see them. These are those glasses. We are one of the first. We are the first that connected the glasses to a smartphone. It has a disadvantage of a cable, but it has the major advantage that you also put everything in the smartphone, so the smart glasses themselves become pretty light. They're the lightest on the market. And what we discovered throughout our journey in DRC and in other countries is that they use the phone quite often, quite well. So I'll tell you when they use the phone and when they use the glasses. That's a little bit the whole setup. Let's go to the case. Maybe first, indeed, there's a lot going on with virtual reality, assisted reality. Those glasses do not have an overlay, which means that you see truly what the world is looking like, but you share this vision with someone who's remote. So it's like over the shoulder. You share, apart from voice, which goes through the phone, also the view that you have while you're in action. And that's important. It's sharing something as if a person was there. And that's a little bit a paradigm shift. A person, remote surgeon or remote doctor, GP can be remote and have an over the shoulder and act and advise the nurse or someone else, a peer, and has the kind of view that the local person in action is having. So it is what we call here assisted reality, not augmented reality, not virtual reality, which is HoloLens and so on and so forth. Our project is 2 days traveling from Kinshasa, 1 day on the road, 1 day on a very bumpy road, but it's pretty remote. And we were together with Mimisa, who was a partner in the project, and Ite as well. We singled out this location because we wanted to prove that we really could reach out to the underserved. I'm going to share some lessons later on, but it was truly very, very remote. The context is the district of Kigandu, where they have 18 rural health centers, and you have to imagine, I think most of you do know, those rural health centers are visited by the district hospital maybe once a month, sometimes even when they're remote, once every 2 months. So there are nurses, skilled people in those rural health centers, but they are left alone to a certain extent. I mean, they have to débrouiller soi-même. They have to figure out how to that they kind of give the treatments and get the patients. We did this pilot in 3 rural health centers, which were rather close to the district hospital. Maybe the first thing, coming back to what you said, Stefan, the technical part is an important part, but it's a kind of starting level. That should be in order. That is a necessary condition. Yes, we do need, next to smart glasses, Wi-Fi, otherwise we can't work, which is an obstacle. If we don't have Wi-Fi, not a big bandwidth, but a certain low bandwidth, but it should be rather stable. Because you're interrupted, you know, if you're in a Zoom call, and you're interrupted every 5 seconds, that doesn't work. So we should have a stable bandwidth, which is a condition. But this technical part and the technical solution is far from the full solution. At least 3 other components are critical. First, the processes. For example, we had to figure out there is a doctor or there are a couple of doctors remote in the district hospital. They can't sit behind their laptop waiting for the nurse to call in a whole day. That's just not feasible. That's a waste of time, of resources, of skills. So how to establish a procedure that when a patient comes and the nurse decides herself when she would like to have the vision of the doctor, when she would start the call. And therefore she's using a WhatsApp on the telephone and she's telling the doctor, in fact, these are 3 doctors active in the district hospital, and say, can I have a call in 5 minutes? So this kind of procedure should be established. We also have certain time frames during the week when we say you should be available as a doctor. So it's not a 24/7. That's an example of a procedure. Infrastructure should be there. The most frustrating in the beginning, and we underestimated that, is that if a nurse does a diagnose and she feels that this patient should go to the district hospital because she can't give the treatment, it's super frustrating if then she sends the patient and the family to the district hospital and the patient never arrives, or the patient then is hesitant and doesn't know how to get there. So we had to be creative and make sure that whatever we advise, that there is a kind of follow-up on what we say. So we had to buy a motorcycle, an emergency motorcycle, only for the emergency cases to bring the patient to the hospital. That's an example of an enlarged setting and infrastructure that you have to take care, without which, in fact, it's rather creating frustration than solutions. And on people themselves, we did, I can't remember, was it 3 or 4 months before we even entered with the glasses? We did a consultation with the whole population. We asked how they would kind of feel and kind of trust. We had to talk to the elderly in the village, when they supported the project. The relation between the nurse and the doctor, which is always a special relation, was there a trust? Who's taking final responsibility? Is it the doctor that is over the shoulder giving advice, or is it finally the nurse that sometimes even going in another direction? So how will that relation play out? Different dimensions, different aspects, which in fact the technology is a minor essential part, but it's just a starting point of much more. Also cost-wise, the cost of the project is not the glasses, is not the communication, it's much more that, let's say, the whole infrastructure that's coming with it. Some numbers, you can see them yourself, but if the nurse finally, when a patient is visiting the rural health center, it's the nurse who decides, should I get consultation from the doctor? And in about 10% of the cases, in the beginning it was more, but then she stabilized, and about 10% of the cases, she tells or asks for an intervention of the doctor. What she's doing, she's taking the phone, she's on the WhatsApp asking whether the doctor will be available, and in the meantime, she's doing an intake with the patient. If it's a woman, whether she was pregnant before, if it's on maternity, how old is she, what's her weight, the basics. So she does the taking, so that the moment the doctor is available after 5 or 10 minutes. So there was always a laptop in the district hospital available, and one of the 2 doctors that were on WhatsApp were then deciding who's gonna sit behind the screen, having the over the shoulder, and that would take 5 to 10 minutes. And the nurse, in the meantime, is doing the take-in. And the moment that the doctor is online, she debriefs the doctor, and then the consultation starts. That's what they figured out themselves, how it would work amongst them. 10% in the cases, she decides, I'd like to have the doctor with me, and I can't read it anymore, but I think in 30%, something like that, there were emergency cases where they both decided this is an emergency case. And then in the other cases, they said, yes, we have to go to the district hospital, but no emergency. Maybe they go there tomorrow or after tomorrow. The successes, and then a bit of the learnings, and I have to read them a little bit together with you. First of all, I think the most important thing is what we learned afterwards is the upskilling of the nurse and the higher quality level that you could keep on demonstrating, because it's kind of training on the job. Training on the job meaning that she's executing and doing the diagnosis, but at the same time, she's supported. And what both the nurse and the doctor told us afterwards is that when a doctor is coming by once every month, he can teach her what she should do and how she should do it. After a couple of days, when she has no practice, she might forget or she might not get skilled. But if you have this constant support or potential for constant support, I mean, the upskilling of the people and the constant kind of high level quality is not guaranteed, but at least much more advanced. That's definitely one thing. The second thing is that the upskilling is not only on the diagnosis. Those people, those nurses now were also trained in rapid diagnostic tests and how to use it, pulse oximeter or other instruments. And when they use that only once a day or once every week, again, they forget how to interpret, how to go about the diagnosis. And this again, then they were not calling the doctor, but maybe a lab specialist or a technical specialist to help them out. So she could enrich her diagnosis over time and make a better diagnosis, even with those kind of equipment that she had available. So these were a couple of, I think, very important elements. You can read the rest and you can have the slides afterwards. On the learnings is, I think I covered some of them already. The first thing is, yes, give me the some of the things. Yeah, maybe I can sit here. That's very nice. That's a good idea. So I think I covered the first one, that the smart glasses without the proper context will not do the trick. The second one I just mentioned as well is that the smart glasses allow to enrich the whole diagnosis and upskill, upgrade the level of intervention. Another thing, in the beginning, we wanted to focus on maternal health care. But if you're in primary health care, very close to the people in the villagers, if someone comes to you and is asking for another type of diagnosis than whether you're a pregnant woman, then you cannot refuse. And at a certain moment in time, it became so famous and so attractive that we had to open up to many more general practice than only one specific support. What is also important is that the nurses financially using the smart glasses, they should benefit from it. Because if they have to invest, they have very tiny resources. These are all low resource settings. If she would have to invest herself time and energy and would then be deprived of some of her income, she would never do that. Maybe there is a very enthusiastic beginning energy, but that will fade away if they don't get the money. And because the incentives were aligned in the sense that the more patients she would see, the more revenue she could get. And so she had all benefits also to make it a trustworthy and a very accepted way of dealing with the villages. And that was tremendous. The visits in the rural health center went up by 70%. That was an enormous trust that they catalyzed. The doctor, however, didn't get any additional incentive. Apart from that, he knew that the primary health care was going up, and that when he was visiting rural health centers at that moment in time, he could enhance even more his support rather than starting from scratch. There was no real financial kind of alignment for the doctor. He was spending also, let's say, half an hour a day for the different calls coming by, so he could kind of support that. Yeah, a lot of things you might know as well is in those kind of settings, the support of the officials, the head of the village was crucial in this entire setting. Another element, maybe the last one, is we started with VSATs because there was no connectivity at all. This was possible because we got the funding from Canadian government with USAID and DFID at that time supporting us. But in the end, that was too expensive. Not only the buying of the whole VSATs, but the continuous communication that became too expensive. So now this is learning. We can't go anywhere anymore where we have to create bandwidth and communication ourselves. We have to rely on available networks and Wi-Fi. The initial cost is acceptable. We know we're working together with Ugani as well, and I don't know anymore what you pay, 1,700 something, 1,700 for a pair of smart glasses and everything. Once that investment is done, it's time, it's connectivity, which is not that expensive either. So once that upfront investment is done in the smart glasses, the operating cost is very, very low. To conclude, if I have another 2-3 minutes, is that fine? Yeah. To conclude and zoom out again, now we have multiple projects going on. As I said before, we have our first pilot in India as well, all in primary healthcare, except one, Médecins Sans Frontières. They use our smart glasses rather for technical support of machinery, equipment, medical equipment, but also other type of equipment. Because that, as you know, very often we invest in hospitals, you said, Stefan, as well, and after a while, machinery and equipment gets broken, it's too expensive to send a technician over there, and the delay, and people forget about it. This allows them to, and that's the relation we're going to build with Ugani as well, that they can, from a remote site, keep the machinery and everything up and running. So to conclude, where we see use cases is both in developed countries where we do it ourselves out of Belgium, but in developing countries, we always ask the NGO or a medical organization to take the lead, and we just support. So Ugani clearly is taking the lead, and we just support Ugani. You could think about physical health, mental health. Frank is on the line. Frank has a major project in Mali that is also in war, post-war kind of traumatic support, helping out through the smart glasses, how they can assist and provide this kind of services. And the last one, which is still a little bit undervalued, is the whole facility and equipment support. I've seen it myself. I think all of you have seen it. It's great to have this sophisticated equipment over there. And after a while, people don't know how to operate it anymore. It gets broken for stupid reasons or simple reasons, and we can't use it anymore. So that kind of uptime of the machinery next to the upskilling of the people, I think, are the two main big values that those kind of smart classes can add. Okay, I'm not going to go there. Let's stop over here.
Thank you very much, Steven. For the audience abroad, if you have questions, you can put them in the chat. we will answer the questions after the presentation of Joren. So we'll go first through the two presentations. And so if you have questions, you can raise them in Dutch. Je mag uw vragen in het Nederlands stellen, in French. Vous pouvez poser des questions en français. Mireille is taking your questions, and after the presentation of Joren, we will have a session, a time, 20 minutes or more for questions and answers. Ah, yeah, okay. Did you, I don't know if you heard what Mireille said, but we can even have questions. You can ask them live to one of the two speakers. So without further delaying, it's an honor to give now the microphone to Joren Vallijs. Joren, he's, so as I said in the beginning, he's an engineer too, an industrial engineer with his heart in Africa. He lived in Benin, in Parakou for some years, I think, and he recently came back. He's one of the founders of Ugani Prosthetics, and he's passionate about improving the quality of lives through new technologies. And I think without further delaying, I can give the floor to Joren, and please feel free to add whatever you want on Ugani, on yourself. Floor is yours.
Okay, thank you very much. So indeed, I'm an engineer as well. As Steven already said before, there's a great collaboration that needs to happen between engineers and medical personnel. And so what we propose is orthotics and prosthetics. I'll just show you a few so you can understand a bit what it's all about. So this is an orthotic. It's like a brace. I don't know if you can see it. Yeah. It's a brace that is made to measure. So we take a 3D scan of a patient's limb, foot, hand, head, even if you need a face mask or a helmet, and then we can put it on. It's quite easy. This one is made for me, but it's of course made to measure for every size. So I can simply use it as a plaster, basically, to fixate my hand if I break my hand or anything. So it's quite easy to do. And I'll explain later what the advantages are of 3D in this relationship. So this is an orthotic. The other product we offer is a prosthetic. I recently gave away my black foot to a patient in Brussels, so it's a white foot. But this is originally, this prosthetics from a lady in Benin. And so she lost her limb in a car crash, motorcycle accident, which is the main reason for most people. And as you can see, we just provided her with a full. Oh. We stopped the meeting. Somebody else is presenting, it seems. Yeah? No? It's back? Yeah. So you can see right on the camera. To look at the camera, okay? Can you see it? And so this is for the lady who lost her limb. She has a new leg. We've fitted about 30 patients so far, because we mainly focus on giving training to local hospitals and local practitioners, and this way we reinforce them, and then we move on to the next site. So we in some countries we do, but mainly we do not produce them ourselves. We teach our partners how to do it. So I'll move to the next one. There we go. So the problem we're trying to tackle, we saw it with our own eyes. It's my co-founder and brother who actually saw it in Kinshasa, that there's a lot of amputees in developing countries who are not helped right now. The numbers vary a lot depending on the country, but in developing countries, we're talking about 5 to 15% of amputees who are helped. So it's about 40 million people who live with some kind of a lost limb. and that have to move forward in life without any prosthetics. So in general, some people do get support somehow, but prosthetics are a very much needed assistance for these people. And so, as you can imagine, losing a limb has a very severe impact on your life. Most people, it's quite the end. They stop. Their job gets hard. Going to school gets hard. Getting money in gets hard. Just moving around is hard. So it's a real life-changing experience. And so we try to help them all the way through to start over again. This is one of our kids that we helped in Benin. And so what we did is try to simplify what already exists. So as an engineer, we hate stuff that is overcomplicated. And we saw that orthotics and 3D, as it's happening right now in developed countries, and the research that goes into it goes to really high level orthotics and prosthetics. We're talking about knees of $500,000, which of course don't benefit to a majority of people. And this technology actually is very widely available. There's actually 3D printers in most rural areas, even in Africa and Southeast Asia. Wherever you go, it's quite easy actually to find somebody with a printer. You would be surprised. The cheapest printer nowadays goes for about $100. 10 years ago, it was 10,000, so prices dropped dramatically. And we actually decided to connect the dots and try to make this procedure using all the best and lowest cost products to actually make a high quality product. It's very easy. We take a 3D scan of the patient. I'll give a demonstration afterwards. We model it on our computer and then send it to the printer. And so our whole procedure for the CPO, which is the doctor or the medical expert who actually makes prosthetic, takes him about 30 minutes to see a patient and to press play. Before, a CPO would have to work about 2 or 3 days full-time works. We're talking 20 hours more or less. And so the big advantage here is the winning of time. And time, of course, is money. So the prosthetic gets much cheaper because it is much faster. So the win in product and materials is not that big. The equipment is expensive, but it's payable and gets reimbursed over time. Of course, you can write it off. But your equipment itself, so the materials used are more or less of the same price as the standard materials. It's just much faster, and so prosthetists can help many, many more people. We also decided to scale up this solution, and this is one of the programs we're running right now or starting next year in DRC, in Kinshasa and in Goma, and it is a full workshop to actually deploy the solution on a larger scale. Where we have a full container that is completely sealed off, because one of the big enemies of 3D printing, I'll talk about it later, is dust and electricity cutouts. And so we have an off-grid container, completely hermetically closed with an aircon in there and air filter systems running on solar panels with its own battery and backup power supply, leading us to print about 100 to 200 prosthetics per month in this facility. So this is really built as a support for existing centers, just to scale up their whole operations and actually help a lot more patients again. I'll first show you the quick demonstration on how we do it. I hope that this works. I tested it before. I didn't take a patient with me today, but I'll give you a quick demonstration on our scanner. Let's see. Here we go. So I'll scan Stefan just because he's here and because we have him as a patient here. I'll just scan his hand and then move forward with a leg. But so you see here, it's quite an easy interface. This is a nearly free app. It's $7. So we're not talking, most scanners that are used by other competitors cost about $5,000. Ours is literally $7 plus an iPhone, but any iPhone can do it. You sadly need an iPhone, not Android, but okay. So you see already my face is appearing. It's a 3D face, it's not a picture. So Stefan, can you put your hand up like this on your leg and try to not move it too much? Like, try to not move it. So I'll just try to give you a demonstration. Here is his hand. And so I hope you can all see it online. I won't go all the way around, but you see how this creates a 3D scan. Now the program is running the rendering. And afterwards, if you zoom in, you see that we have a full 3D model of Stefan's hand. And with this, I can go on my computer and model it. I won't show you how that goes because it's, well, half an hour and then I won't have time to present anymore. Let me go back here. So that was a quick demonstration on how we scan. So this is a very concrete example where $7 does exactly the same as 5,000. And that's just, we didn't make this app. We didn't rewrite the code. We are rewriting our own version of this, but it's already out there and then you don't need to reinvent it. The scan quality is perfect and allows us to make a perfectly fitting prosthetic or orthotic or whatever is needed for the patients afterwards, also using open source software if needed for the patients. So now let me get to my final slide, or the last one, the most important. This is our quick analysis. I was asked to talk more about what are the advantages and disadvantages of digital for developing countries, for low and middle income countries. And we listed a few. Of course, it's not an exhaustive list. But we faced some difficulties, of course, over the last few years, and we've seen some advantages of our technology as well. So one of the biggest advantages and strength of our solution definitely is the speed. That's what I said before, the accuracy as well. So speed is very important because people need to be paid. A person that works 10 hours is more expensive than a person that works 1 hour, and more patients can be helped. So as I said before, there's only 5 to 15% of patients that are being helped. There's a lot of centers out there, but we just can't do it right now. There's not enough people to actually help all of the amputees. And by speeding up the whole procedure, we hope, we are right now at 10 times faster. We hope to be able to help more people just by handling more patients in the same centers and speeding up the whole procedure. Another advantage is accuracy. So traditionally it's made by hand. An orthotic or prosthetic that is made by hand, of course, depends on the quality of your practitioner, of the certified prosthetist. There are very good ones, and sadly, there are not that good ones also. It's a very manual labor, so it really depends on how you do it, where you learn it, to which school you went, which school you follow, on how you make it. And so the quality for the patient as well is every time is different. With digital, we can just reproduce it 1,000 times exactly the same. If a patient comes back with an issue, we don't have to start over from scratch. We can just modify the file a little bit so it's better. And so you have this traceability and this repeatability in your digital, which is a huge advantage. It also allows you to follow up with a patient. So if a patient comes back after 2 years, you can see the evolution of the stump, which seems like it's not very important, but if the stump is getting very narrow or is having some pain points, you can already start seeing that there are some future issues that will appear if you don't treat the patients accordingly. So having it digitally really makes it traceable over time. Then what is very nice about our solution is that it's open source or nearly open source. The software we created ourselves, we want to keep it open source. And more tech companies are going into that direction, at least making software open source. And it means that everybody can also contribute to it. So if a practitioner somewhere feels that he wants to add this option, he can ask us and we will have no issue with doing it. If somebody else is a programmer, he or she can also contribute to the program and actually improve it. And this only makes a better program in the future. So our software, modeling software, is based on Blender, which is an open source program. And it allows you to actually keep learning and keep getting better without it being restricted with payments or anything. Another advantage that we found is that there is a lot of different options out there. So you can use the open source tools like we use, but if you want very user-friendly, like the Ferrari version of the software, it also exists, comes at a price. So you would have to pay a couple of €100 per month for these softwares. Most major players have it, but you can, if you prefer to pay and have like, it's mostly the ease of use that's the big difference. The quality of the product stays exactly the same, but it's easier to use their programs. So if you want to do that, you can do it. We also partnered up with Spentis. So Spentis is another Belgian startup, and they actually helped us to create these. And so they have an iPad app, which is much easier in the ease of use, but it's not free. And so for us, it's a trade-off. We always offer our partners the option. So with us, you can choose, or you get the whole thing going and you pay a monthly bill. but then you need to force to be able to pay it, or you go to the lower cost option, and that's also working fine, but it's a little bit less user friendly. You have to save files on your computer and send them from your phone to the computer, and it's not one streamlined procedure, but it also does the job perfectly. And then that's of course the main advantages. For the problems or the issues we had, I'm going to list a few. Expensive. So depending on your country, on your region, 50 euros, $50 might be a lot or not, and that's really depending on the patient. We have seen patients that could not pay $1 for a prosthesis. We've seen others that could easily pay 10,000. So it's a really big difference on where you go and which people you meet. And so 3D is not necessarily cheaper in say, it's only because it's faster that it actually gets cheaper. But the price of the prosthetic, of your foot, of your pylon, of the socket still needs to be paid. And so it's cheaper. We're trying to sell at about 300 euros. That's our target price. We're a bit above it, but we're very close. Most competitors are at more than thousands and actually even higher in Belgium. It's more like 5, 6, 7, or 20,000 euros. So we're way cheaper already, and still it's not enough. So that's for us a very big struggle, and I don't think digital will completely solve this problem. And then of course, is it made, if the technology is made for high-income countries, that often gives problems. So most 3D printers and 3D scanners are tested in labs in high-income countries, or maybe in China. I don't know where they are, but the ones I've used were mainly made in the USA or developed in the USA. And the climate is different, humidity is different, the dust in the air is different. So for example, we bought a 3D scanner in the beginning of 1,000 euros, and it simply did not work. I don't know if the scanner was racist. It did not recognize a black person's skin. It just did not detect it at all. So we paid 1,000 euros, got the money back when we complained, of course. But that for us was a shock. And they did some research and found out it was because of the dust particles and the humidity in the air that the light was actually blocked. So it had nothing to do with the skin, of course. But that was, for us, was something that they did not test in their lab. And that's, well, most stuff is made for drier climate and less humid and less dusty. So the same goes with our printers. We selected the right printers and the right software and the right technology to be able to, and we proved it, that it actually works. So our printers are running. They are printing, and it all actually has no issue. We made all the tweaks that are needed to actually get it going. And so you often with digital have to make a little adjustment to make it work in a different settings. We found out, but it's not too hard. Then, as Steven already told, you have a need for infrastructure. We don't really need data. We need to send the scan from our phone to our computer, but you can just make a personal hotspot. We don't need satellite or heavy connection internet. But it is always handy because our systems are also stored in the cloud if there's a crash. So we don't need a constant bandwidth, but sometimes we need internet to make sure that data is not lost. And that's something that in some places is not available. So we are also dependent on this. And that is geographically, in a majority of cases, people who actually need help most are still hardest to reach. And that is just it's just a reality that technology cannot solve in its whole. The same with electricity. A 3D printer needs strong, stable electricity. So we have to build a whole system next to the local grid just to make sure that when there's a power cut, we don't lose all the work. That's also in Europe. So it's not only in developing countries. We have it here as well, because blackouts don't happen often here, but they also happen, and it can also just be a wire at home. But we don't want to lose all the work we've done. So we need stable and backup infrastructure. And then the biggest disadvantage we found is the digital knowledge gap, which some NGOs and companies are trying to face and to tackle. But we see that the people we trained to use the iPad and the computer are often digitally not so schooled, and so we often need to teach them quite, for us, basic skills to start with. And when you have to learn to teach someone how to start up a computer, to then teach them how to model in 3D on a computer, the gap is just too big, and it's very hard to overcome this gap if you don't start with digital training from your early years. So we really support all this training and this school coding camps, and where children actually get to know all these medical devices, these media devices, because it will be needed in the future for sure. Then very short opportunities. We are absolutely convinced that this is the way forward. If you look at in Europe, there's still only a minority of practitioners who use 3D for orthotics and prosthetics. It's still a rare breed that does it, but everybody knows that this is the future. It might take 20 years or it might take 1,000 years, but this will for sure be the future. 1,000 years, I hope not, because then we would have a problem. But it will happen at some point, and so for us, it's very straightforward to move forward with this. A big advantage we have that we still need to work on more is the easier supply chain, because it's just one printer, and then your what you need to get in. Even if you make a print or a part that is this big, it's just some little grains of plastic you get in. So your transport is much easier. Your whole logistics is much easier to keep going. For traditional prosthetics, they need to ship these massive sheets of plastic that are about 3 meters on 2 meters, which is very big, of course, and so it's special shipments, and so it's not standard transport, so it's very expensive to ship. We, to Ghana, where we're active, we actually give our rolls of plastic with the pilots of KLM. They take them in their backpack, and it works. It's of course not on the long run, but it's much easier for the supply chain than the traditional ways of going. And then threads. I listed absolutely the gap in digital knowledge between low-income countries and middle-income countries and high-income countries, which I think is very real and needs to be tackled. Otherwise, the global north will move forward faster, and the gap will only keep growing, and it's a problem for all of us. And then what we found, I can't really name, but there's legislation in some countries that is not helping this move forward. There's laws that are not really pro-digital innovation or pro-innovation in general, and that actually slows down our progress. But that is, I think, a very general threat for digital. And that was it. Feel free to reach out to me afterwards, and we are open for questions, I think.
Okay. I don't know if there is some hands raised already, or if there is questions in the chat. I have.
Yeah, so right now depends on the center. So our partners are in general independent hospitals, so they do what they want. We don't want to force them in a way of thinking. We give them the solution, and we explain and we do the calculations with them how much it costs to make this device. If they want to sell it at a high profit to some more wealthier patients, they do it. They also give some for free. So we let them do their own financing. We don't do that. In countries where we are active ourselves, like in Ghana, and we're going to launch Kenya soon, we will try to make the smallest profits possible, of course. Well, it still needs to be viable as a company. And so in the beginning, when the volumes are still low, we usually sell at about 500 and it goes down. And we believe that with time, with all technology getting cheaper, that prices, it has a bottom limit, of course, but price will only go down over time. So I strongly believe that in a few years, a prosthetic for about $100 will be, or is a realistic goal, actually. Somebody took over again.
Maybe I have two questions. The first one is to Steven, and it's on the software you're using with the smart glasses. Is it 3D accessible, or is there some licenses to be bought to be able to use the smart glasses? I've been trying to push our technicians in Burundi, for example, for the maintenance, the biomedical maintenance, and surprisingly enough, and I don't know if Farah is in the call. Farah Ben Yacoub, I don't know if she's in the call, but the reaction I got was, well, we are fine with WhatsApp. For a technician, I mean, that's a feedback I got, that for an engineer working on a radiology equipment, they say, well, we can film with WhatsApp and it's fine for us. But for doctors and nurses, I think there is a really added value to have your hands free and to wear these glasses. And so my question was on on the application you need to run on your phone. And then I have a question for Joren as well, but that's more on the rollout. I mean, if you go to Kinshasa, you install your production unit in Kinshasa. We know Congo is having over 600 health zones and hôpitaux de référence. So would it be an option to put the scanners and to do the scanning in the hospital and then send the data to your central unit and to print and then ship the prosthesis or orthesis to the hospital? Or is that just a bridge too far? Is that not possible? It's just curiosity.
Yeah, thank you, Stefan. I was just sure it's a bit like you said, Jurgen, it is, you have free software, which is available, which is less user-friendly, but with some of our industrial partners that provide software to the glasses, we also have an agreement that if we use those glasses for underserved populations, they give it for free as well. Because for us, we have to physically make those products, so we cannot give it for free like our prosthetics either. Software, once you made it, it's off the shelf. So we have agreements with a number of partners that provide those software for free if it's truly dedicated to the underserved. If that is not available or wanted, then there is also other software where we invite partners, like Frank is also connecting this and writing his own software on the glasses. He gets the keys and so he can develop that himself. So there are a couple of ways. It's never the stumbling block. It depends a little bit again what you're looking for and how sophisticated you want to have it. On the other part of your question, I think it is a very valid question. We're not saying that glasses will solve everything. You have to go to the business case. And for certain applications, WhatsApp is super great. I mean, yes, it's absolutely, you can use it. But you said it as well, Stefan. WhatsApp is in other business cases. When you want to be in the job, active, eyes on the job, or on the patient, or on the machine, if it's about the maintenance, and you want to teach it while they're doing this, we see over and over again that WhatsApp doesn't work. First, you're moving around, you're not very stable, you put it away, you have to do something, you have to call again. So the vocational training, as we say, is much better in certain areas with glasses, but not in all.
Okay, very interesting. Yeah, as you said, we're going to use the free software when we implement your glasses in Kinshasa. So we use their glasses for our project in Kinshasa as well. And so one of the ideas or one of the projects we have there, and we are trying to roll out in Senegal as well, we're talking to the government there to do this, is, as you say, have a central production unit. And then, as I said before, our scanner is very cheap. It's very affordable. And so we would like to send the scanners just around and have people actually mobile. So a big advantage that I didn't list before of our digital solution is that it makes the whole procedure of fitting a prosthetic very, very mobile. We can just give a scanner, this phone with anybody that goes on the field, take a scan, print it back in the hub or even nearby, and then ship it over to the patients. But then the care still needs to happen. So a patient is still a patient. When you just give them a prosthetic, their problem is not solved. They need physiotherapy, they need to learn to walk again. And so just going to a super remote area, scanning a patient and sending him a prosthetic, him or her, does not solve the problem at all. Then we have resolved nothing because the prosthetic will not be used. But if we have some smaller cities or smaller medical centers like you did in your project with distributed care, and we give them scanners and get the data back to one central hub, we can perfectly print it, make the alignments, make the prosthesis, and then ship it or send it over there and then have the local practitioner fit it to the patients. There's always a little aftercare that needs to happen. So not only the physiotherapy, but also the alignment. So your prosthetic is printed, not the whole part. So it's really the socket, the part that connects to the body that is printed. The rest is just attached to this part. And there's still a little alignment that needs to be made. So some people have their leg going a little bit sideways or backwards or front. And so we need to make some small adjustments when the patient is fitted. This takes about an hour, can be 2 or 3 hours, depending on the patient. where we really look at the patient walking and back and forth and see if they have a normal gait, see if the height is perfectly equal. Because if the alignment is not perfectly done, go forward 1 or 2 years, and the patient will have issues with their back, with their other limb, with their other knee. So the fitting is a very important part. And so the printing centrally in a hub can work. Of course, here it's very easy. Here you have BPOS or DHL next day delivery. In general, the areas where we try to help, they have these kind of systems, but they're very expensive. In areas where I work, for example, we tried to deliver a prosthetic to a patient, and that was about $15 added to the bill, which is not a lot, but it's still this extra gap and this extra step that you need to take to actually fit it and to make it work. So we are absolutely looking into it, because this is a strong way forward for us as well.
I think in our talks as well, what was for me at least interesting, and I think you as well, where we decided that we're going to try this with the glasses and Ugani, is you had a very successful project. I think it was in Ghana, but you were there on the spot. You helped them out and stayed a couple of weeks, if I remember well. But when you went back home and you left them, you saw how it deteriorated quite fast, and that's very frustrating. And if you can't give that ongoing care from a distance, whether it's a breakdown in your printer or whether it's an assistance to the doctor or whoever, then that's what happens so often, that good intentions, great project, but it remains a project. It doesn't become an ongoing process. And that's what we try to kind of accomplish together.
Just if the main to get a job wants to reach.
She's now unmuted.
Allô, oui?
Allez-y, vous parlez.
Oui. Bonjour, tout le monde.
Bonjour. Bonjour.
Bonjour, Stéphane.
Bonjour.
Merci. Donc, je voulais juste vous exprimer mes félicitations et vous dire merci pour cette présentation. C'est vrai que ça a été fait en anglais et que je suis francophone. Je ne suis pas très forte en anglais, mais par rapport à tout ce que j'ai pu voir sur les diapos, donc je me débrouille mieux quand c'est par écrit. Donc, d'après ce que j'ai pu voir sur les diapos, je disais que ces solutions digitales offraient vraiment des opportunités aux populations, et notamment en zone rurale où les services ne sont pas toujours accessibles, surtout par rapport à certains services. Donc, avec la télémédecine et aussi l'accessibilité à certains services de ce type pourrait vraiment être bénéfique à ces populations rurales surtout, étant donné que pour ce type de service, il aurait fallu dépenser beaucoup plus parce qu'il faut un déplacement vers les villes, donc il y a tous ces frais-là liés au transport, à la prise en charge alimentaire et tout ça à prendre en compte. Donc, le fait qu'il y ait ce type de solution digitale était vraiment à louer, et que ça pourrait aussi, d'une certaine mesure, faciliter le traitement d'urgence. Si je prends l'exemple d'échographie, il faudrait peut-être aller vers les villes, et avec la télémédecine, on pourrait régler ce genre de situation. Et aussi que ça pourrait renforcer l'expertise locale, donc avec les échanges avec d'autres, des experts d'autres pays. Donc, que tout ça, c'était vraiment une aubaine, si je peux m'exprimer ainsi. Donc, merci vraiment pour cette présence.
Avec DeepL, on peut traduire tout en français, je crois, non?
Oui,
Tout ce qu'on a dit, avec DeepL, on traduit et voilà.
En tout cas, merci Khadija pour les encouragements. Je ne sais pas s'il y a d'autres questions. Moi, j'en avais encore une pour Steven. C'est en fait, je la pose en français, c'est les informations qui sont générées dans le cadre de l'utilisation des smart glasses. Qu'est-ce qui se passe? Est-ce que c'est stocké pendant un certain temps? Et aussi, est-ce qu'il faut un accord du patient avant de pouvoir utiliser les lunettes? Ou est-ce que, comment c'est géré? À vous, Steve.
Yeah, again, a very interesting question. First of all, every patient has to sign a consent form. So that is standard procedure. Whether they want to, when we apply the glasses, that's standard procedure. On the data, you have two options. First option is that it's not stored. It's just kind of going back and forth and it's in the moment and afterwards it's gone. But the more advanced application is that you start to store those data. Of course, with GDPR and everything should be in order, but you take photos, you take diagnosis, you can, on the phone or with the glasses, you can record. So little by little, and that's, for example, what Frank is doing, he's connecting it to the backbone, to the, let's say, the more administrative part of the process. So it's a great gateway also to capture data, store data, and reuse data. But you can go both. Or it's online and it's gone, or it's online, you capture, you store. But that should be defined up front in the whole kind of, so it's a frontline capture, which you could extend later on.
There is another question. Frank, here present with us in Brussels.
Yeah, thank you. So I'm Frank. I'm Frank Ziza. I'm from Burundi. So I'm here for specialized master in public health, but originally I'm from Burundi, the president of Burundi Health Informatics Association. So my question for Stephen is a question about infrastructure. So what about the quality of the video which is transmitted to the remotely to the health profession, to the doctor? Because sometimes we don't have good internet and the resolution of the video is not, or I mean the quality of the phone you are using in terms of the cost or those things. So that's the question about the infrastructure and the material you are using. And for you, is a question about the supply chain itself. So the material you are using, the plastic, the factory. So how are you managing the whole supply chain? So where is the factory? Stefan talked about that a little bit, but I'd like to understand the whole supply chain from the from the scan to the print or the supply chain. How is it working? Because sometimes the problem you are solving public health problem relating to entities, but sometimes the whole problem sometimes related to the supply chain. Sometimes the technology, the material is available, but the needs is on the ground, and sometimes we don't have the whole supply chain to make sure that the technology and the materials is where it's needed. So thank you. That's my question. And a small comment about the person who said that WhatsApp is fine. For example, when you are doing the job, I'm personally medical doctor. I know that is it doesn't work like that. WhatsApp and your and the smart glasses, it's totally different as you say, because sometimes, the quality of what you get from WhatsApp is depending on the quality of your phone. But the glasses, are bringing a new, a new technology because they are bringing the camera also, which is not always available on your phone. You have WhatsApp. So that was my comment. So to me, that the person who said that maybe he was not considering all those aspects that we are facing on, the ground as medical professionals.
Very quickly on the phone, we support multiple types of phones, both Android and iOS, and you can get a good phone as of $200. So the cheaper models do function. We shouldn't go to the 6, 7, or 1,000 euros. 200 euros is good enough. Second, on the bandwidth, we did tests and very recently actually with Médecins Sans Frontières, because they test really the bandwidth and the stability of the bandwidth. And we can go pretty low, under 1 megabyte bandwidth. That is good, but the stability is more important than the bandwidth. And the bandwidth depends a little bit on what type of functionality, advanced functionality you want to use. The basic functionality, you see what I see, and over the shoulder, 300-400 kilobytes is good enough, but the stability is quite important. And the stability is much more for the interaction. It's the same as I said in the beginning. If it's interrupted all the time and the nurse is dealing with a patient and then she get disconnected, and then the doctor logs in after 1 minute, that's not very smooth and not very patient friendly. So it's more that aspect than anything else.
Okay, and so for us, the supply chain, so majority of the products or the parts and components we use are outsourced. So we work with suppliers to get them in. And so we have had some negotiations with DHL, which is one of the biggest players in Africa, sub-Saharan Africa, worldwide even. But our volumes are still too low to actually really take care of this on a higher level. So that's a bit the issue that many hospitals that we worked with have as well. The moment you stay small, it's hard to order a full container to be shipped every month. And so you need to get small packages over. So as the example I gave before with Ghana, I went over there with the printer in my suitcase and that worked fine. And they have a printer and it works. The phone, you can just buy it there. And the filaments, so the spools of plastic that we get over there, they come with the pilots of KLM. So it's a very stupid example of what goes. Of course, the moment you scale up, it doesn't work anymore. In other countries, like in DRC or in Benin, where we're active as well, there we actually ship it over and just try to do it with local partners as well. So there's a lot of NGOs who have the NGO status in these countries. And for them, it's often easier to ship in and out, to ship stuff in and out. And so we try to, when we go to a partner, we train them on the whole digital workflow, how to take a scan, how to model a patient, how to print the prosthetic, but also how to do the maintenance of these machines. And so when we give, or when we sell a printer, it comes with a whole bunch of spare parts that we know will probably break in the coming years. So the package, the basic package, already comes with whatever you would need for the coming years. So you're sure for that, you don't need supply chain for these parts. And then your filaments and, for example, a prosthetic foot or a prosthetic knee, an artificial knee, with the centers we work with, they already have an existing supply chain going on. And so we just try to, we re-evaluate it with them. We look at what do you have here, how do you do it now, and how do our products fit in this line? And so we really adapt it to their needs. So that's 2 days of the training program where we do that with them, really implement this digital solution in your center, because just training them how to do it wouldn't change anything. There needs a flow in there. A patient comes in through that door or that door. Where do we set them down? Where do we save the scans? Often they have their own email system or their own digital system already. We integrate it with our system so that the data is saved in their systems. And so all of this is done with our partners. And then in the countries where we go ourselves, we just try to build a stock, as always. And that's the advantage of what we do, what I said before. With 3D printing, you can buy a quite cheap roll of plastic and you can use it for whatever you want. So you don't need to buy 1,000 different parts. You just need a few rolls, and in total, we need about 10 different components. And that's it. So we can have a stock of 10 or 20, depending on what it is, of each of these parts from the beginning, and then just keep the stock going. And we don't really have any critical part that is there. One of the biggest issues we have is the foot, because the foot is the rest of the parts we can easily adapt to patients, but a foot comes as you buy it, and there's two sides, so left and right, so you already need everything 2 times. There's different for child, adults, female, male, and there's different types of feet. So everybody has different shape of foot, and we try to match it. And so you need a bigger stock, and then also your size of shoe. So you can buy it in centimeters, so you need one of every half a centimeter length. So feet, you need about 20, 30 in stock at every time for any patient that walks in. But then we can also do an emergency order if it's needed. It takes 2 weeks, it's more expensive, so it's stupid loss of money. But if it's really needed, we can do it. And in general, we try to have a just strategic stock always there to keep going. That's it's part of it. Like, it's a tricky part of it, but it works so far.
S'il n'y a pas d'autres questions, moi je pense que je vais encore une fois applaudir les orateurs, remercier de tout cœur Mireille qui a tout organisé, qui a été vraiment magnifique dans l'organisation de cette réunion. Remercier les gens qui nous ont suivis à partir de l'étranger. Je vois une main qui s'était levée, mais qui... voilà, Philippe.
Oui.
Philippe, tu veux encore, is that a question, or you just want to say hi and greet all of us? Tu peux parler, hein? No. So no, so thanks again to everybody. And so we in Brussels, we will have a drink. And I suggest you have a drink as well in your countries far away. And see you next year, 2023, at the conference of Because Health. But to be there, maybe good to look at the call for abstracts, because by the 6th of January, we are waiting for the abstracts to be sent in. But one track will be on digital and innovation, and the central question, did it work? What was the added value of all this? And so I think there's been a lot of things to be shared in this conference in 2023. Yeah. So bye-bye, everybody. Prettige feesten. À la prochaine.
Bye.
Bye. Bye.